Welcome back inside the Now Morning Show as we continue to go beyond the numbers for the National Budget 2024-2025. This morning, I welcome the Minister of Health, the Honorable Terrence Deyalsingh, who joins us live in studio on set. Good morning to you, Minister.
Morning, Ruckus. How are you?
So far, so good. How are you doing?
Not too bad, my brother. Good morning to all your viewers and listeners.
All right. So 7.571 billion. That's the number that was given in Parliament on Monday. That's allocated to the Ministry of Health. Firstly, how do you feel about it? Was it the close to the figure that you would have requested?
Yes, indeed. The Minister of Finance, through my 10th year as Minister of Health, has always been very good to us and given us enough money to run things. So we are quite pleased with it.
All right. So out of that 7.571 billion, how much of that is recurrent expenses?
The vast majority. So let's, and you were going to ask that question. So of that budget, remember the Ministry of Health gets the money.
Right.
The Ministry of Health runs some departments. At the ministry, we have about 2,000 persons employed. But the vast amount of money goes to the RHAs.
Right.
So roughly about 80% of that of those 7.5 will go to the RHAs. That's to cover their expenses. And roughly about 80% of that is recurrent.
Right.
So you can see the vast majority of the funding is for recurrent.
And just to be clear so that everybody understands what we mean when we say recurrent, we're talking about things like salaries,
salaries, wages, TNTech, WASA, those things that you have to pay on a monthly basis to keep things going. And the vast majority of that recurrent is salaries and wages. So throughout the whole health ecosystem, you have 21,947 people employed.
Right.
And the vast amount of that 7.5 billion is for recurrent, and the vast amount of that recurrent, about 80%, is salaries and wages. Now, Ruckus, when you consider 21,947 persons employed, if each person has 4 or 5 dependents in a family, you start to realize that the health system, the employee base, affects close to 100,000 people.
But of course.
Yeah. So it's
it
a very big employer.
It affects more than that because, besides the people who are directly employed, there are people who would also gain, extra,
services.
The services industries and that kind of thing.
Yeah.
All right. So then that's recurrent expenditure that we know you have to deal with regardless because people had to get paid, bills had to pay.
Exactly.
Right? We also now have the PSIP, which I understand 464.3 million has been allocated for the health sector. Now, can you break down for us, when we say the PSIP, this is the part that I am often most interested in, because this is the part that we see in terms of what's new, what's developing in terms of the Ministry of Health and how we maintain and upgrade the hospitals.
Yeah, so the PSIP is a program where we break down expenditure into categories. So one, we go for medical upgrade, where you replace equipment, you replace ventilators, you buy new equipment. Then hospital upgrade, then physical investments.
Right.
So those are the 3 main categories under which your PSIP spend is concerned.
Right.
So equipment, we've explained that. I think the population can grasp what equipment is. Then you have the hospital upgrade program, which is to upgrade your physical plant, your buildings. Right now, under the PSIP, and for the past year, and in this year, our 3 legacy hospitals, that is San Fernando, Eric Williams, and Port of Spain, they have been undergoing significant physical upgrades. Not only painting, but new bathrooms for both staff and patients, because those 3 legacy hospitals, Port of Spain over 100 years old, Eric Williams was built in the 80s, San Fernando probably about another 100 years old. Over the decades, not much attention was paid to upgrading them. So we have started that since last year's PSIP, which will continue into this year's PSIP.
And that also included the new central block at Port of Spain General Hospital as well?
New central block is not a PSIP project. That's a CAPEX. That is a capital project funded by loan financing, not under the PSIP.
All right.
So
fantastic.
new hospitals aren't funded under the PSIP.
All right, and it's lovely to clear that up.
Yeah.
In terms of the hospital upgrades themselves, you mentioned the bathrooms, you mentioned the painting, you mentioned stuff like that. A lot of times,
and so on.
roofing and all that. So that's the physical upgrades we're talking about. In terms of the actual equipment in the hospital, that falls under the PSIP as well.
Yes. So remember I said under PSIP you have equipment upgrade too.
Right.
Yeah. So some monies are allocated
to that. When it comes to the public is always very interested because their experiences, they go in the hospital and they either get through, as in they get served properly and everything goes well. But we've seen several reports, or some reports rather, and even up to Monday when we were in the streets talking to people, some of the concerns was I go to the hospital and I still see people sitting down in casualty, as they call it, the accident and emergency section, claiming that there aren't enough beds, there aren't enough wards, there aren't enough this, there aren't enough that. Are there plans, or have there been plans in the last fiscal going into this fiscal to address some of those issues? Or how do we prioritize if we're doing fixing bathrooms or we buying more beds, or how do we prioritize where the spend goes?
Okay, so let's look at the ecosystem of health. If you went into Port of Spain, yes, you will get that complaint in Port of Spain. Why? You have to remember after the earthquake in September 2018, we had to evacuate Central Block, which was 400 beds. Even though we ramped up bed space in St. James and the Costard building in Port of Spain, we are still short some beds in Port of Spain. So that is going to be an issue. So once Central Block in Port of Spain comes on stream, March, April next year, that will no longer be an issue. But you don't hear those complaints as much as in Point Fortin, Arima, Sangre Grande. But let's try to educate the public as
That's
far
why
as
we're here.
casualty is concerned. An accident and emergency room is not first come, first serve. In other words, people don't form a line and I attend to the first person, then the second person, then the third person. You attend to people based on the severity of their complaint. So if number 10 is life-threatening, you see him first. So number 1 is going to have to wait. If number 8 is also life-threatening, you see him first. If number 1 is a bee sting or a slight cut that is not life-threatening, you don't see them immediately. We operate what is called a CETA system, Canadian Triage Acuity System, grades 1 to 5. Grades 1, which are life-threatening, you see first.
Right.
So I hope that we constantly have to educate the public. And this is around the world.
Yeah.
This is around the world.
But I imagine anybody who's making their way to an accident and emergency or hospital in general, they think that their problem is priority.
Yes. And we understand that.
Of course.
Yeah.
All right, so tell me about I want to talk a bit more about the medical equipment upgrade program.
Sure.
I understand that 60 million will be directed towards that.
Yes.
Can you give us a breakdown of some of the items that we have on the agenda to purchase this year?
Yeah, so that will be things like infusion pumps. That will be things like cardiac monitors. That will be things like fetal monitors, neurosurgery equipment, stuff like that, oxygen concentrators and so on.
And is it that the RHAs themselves request what they want and you facilitate that request? Or?
Yeah, so the budgeting process actually starts months before.
Of course.
Where we send out to the RHAs, look, tell us what your needs are, prioritize your needs under the headings: physical investment in grade, hospital upgrade, medical equipment. And then we make a submission to the Ministry of Planning and Development. The Ministry of Planning and Development sees about the PSIP, not necessarily the Ministry of Finance.
Right.
So that will be Minister Penny Beckles-Robinson. So each ministry will make a presentation to the Ministry of Planning and Development, which comes up with the PSIP program.
And I understand that $176 million has been allocated to specialized healthcare services, which includes things like renal dialysis and treatment of adult cardiac disease. And also, very interestingly, the waiting list for surgery has been allocated $6 million. Tell me about the importance of allocating this amount of money towards, because renal dialysis alone is $150 million. Can you explain in terms of the value of these things and why it costs so much?
Well, currently, we have about 1,000 persons on renal dialysis. If they were not receiving those free services, they would die. Because to go on dialysis means that you have end-stage renal disease.
Right.
So without dialysis, those 1,000 people who receive that service at little or no cost to them, they would not survive. We also provide dialysis in the RHA system. Cardiac services, under the EPP, 3,880 persons receive cardiac services at a cost of $52 million for 3 years, from 2021 to 2024. They don't pay for it. That is done. Vitreoretinal surgeries for your eyes.
Yeah.
So we do all these things under the PSIP. Right?
Right.
Which are absolutely life-saving and life-changing.
Of course. And the fact that I wanted to reiterate it because I don't think people understand the value of what they get for free when they go to the public hospitals here in Trinidad and Tobago. Tell me about the wait list for surgery, because I understand $6 million will be appropriated to meet payments for some of these services that we just mentioned, the emergency procedures and stuff like that.
So these are not necessarily emergency procedures. These are some procedures that are not immediately available in the public health system. So we farm it out to the private sector. Right?
How come they're not available in the public sector?
You have to recall, you have to remember, and people think that this doesn't apply anywhere else. Both the public sector and the private sector work symbiotically. There are many things the private sector can't do that we do for them. And there are one or two things that we can't do that they do for us. It's a matter of availability of specialties. Many specialty surgeons, we can't pay them enough to work in the public sector.
To keep them on staff.
To keep them on staff.
Right.
Right? It's simple econ.
You know, I love that you brought that up, right? Because I didn't plan to ask this question, but as you bring it up, right? How then do we deal with the aspect of the accusations, maybe I should say, that some doctors are employed in the RHAs, they are employed in the hospitals, and they still perform their private services, and they tell people, well, come and check me in the private.
It's not an accusation. The contracts with the consultants allows them to work privately.
How do we then measure their input when they work in for the government versus when they work in private?
Right. So you may recall when we first came into office, the Honorable Prime Minister commissioned the Wealth Report. The Wealth Report, one of their terms of references was to do just that.
Right.
In the main report, they could not make a recommendation to stop or to solve the issue of the private-public practice. They then submitted a minority report. We took that report to the Parliament and asked the opposition, let us have a joint select committee to deal with this issue once and for all, where we could have it in the public, bring in the specialties, bring in the doctors, bring in patients, have a joint select committee, government, opposition, independent senators. So this issue could be aired in public and solutions found. That was our approach to solve it. The opposition leader refused.
So it means it just dies there one time?
It died because we could not get the mechanism to air this issue in public.
And is that the only way to solve it? Is that the only way to find a solution?
It was the way that we thought best to do it.
Right. Okay. So then we just here with it happening and nothing could be done?
The terms of contract allows it to happen. That they work, I think, 28 hours in the public sector and then they do their private practice.
Yeah. I mean, there's also an allegation of, use of public supplies. So from the hospital and they use in their private practice as well. Do we have any mechanisms in place to deal with that? Or would we need the same joint select committee to air it as well?
Well, that's an allegation. If you have evidence, bring it to me.
Understood. I want to jump across to policy as well now, because I mean, that is primarily your role as a minister, to deal with policy. Tell me, any plans for any policy upgrades in this fiscal year that's approaching?
Yeah, so the policy, we are working on 4 major policy positions. 1, reduction of NCDs, non-communicable diseases. 2, HIV. 3, the further decentralization of mental health services and for the conversion to the country from the CHIT system of blood donation to a truly voluntary blood donation system.
Right.
Those are the 4 major policy drivers that we have been doing for the past 2 to 3 years that will continue into this fiscal. These are not things that you accomplish in 1 year.
Right.
These are multi-year programs, policy programs.
Tell me about the HIV policy and why they need to focus on it. Is there a rise in cases? Is there
No, they are not rising cases. But what has happened is that we have signed on to the United Nations Declaration that HIV, as we know it, should be a thing of the past by 2030.
Right.
And we have certain targets to hit by 2030. The targets go like this: a country should have 95% of its known HIV people on drugs.
On the treatment.
On treatment. And 95% of those should have their viral load so suppressed that makes transmission next to impossible.
Right.
So it's a 95, 95, 95. We are currently at about 93, 68, 93.
Okay.
So we have some work to do still, but we are not in a bad place.
Right.
As a matter of fact, we're in a pretty decent
I know,
place.
saying that sounds like a good place.
It's a decent place.
What does the public need to do in order to assist with that process? Is there anything?
Yeah, the public needs to come into us, one, to get tested, know their status. We are working hard to decrease stigma around that. Once they know their status and they are positive, they have to go on antiretrovirals, right? And take it regularly and take it as prescribed, and then do their regular testing to see where their viral load is. So that is what the public can do. We estimate in Trinidad and Tobago there are about 11,000 persons roughly living with HIV, and we know about 93% of them. So we're not too bad with the first 95.
Right.
Where we need some help from the public is that 95% who know their status have to now be on antiretrovirals. And that's where we are about 68%.
And why is that?
Many people don't like to admit that they have HIV because of the stigma,
right,
and don't want to take their drugs.
Okay. So it's not that the drugs are... Is there a cost to the drugs?
No, these drugs are free.
All right.
These drugs are free, right? Plus, people change addresses.
Right.
They change phone numbers. We can't contact them. That's another challenge for us.
Yeah. All right. We only have a couple of minutes left, and I really wanted to get into one of the policies. You didn't mention it just now, but the health digitalization policy.
Yes.
I understand it's 80% completed. Can you just explain to us what that policy is all about and how we gonna put it into effect?
So some components are 80% completed, not the entire thing.
Okay.
As the Minister of Finance said, by end of 2025, we should be finished. So it's a matter of moving away from paper records to e-health records.
Right.
Right? Which will, because one of the genuine complaints you get, which I cannot defend, is lost records.
Oh, yeah. Because I was going to give you some first-hand information on that.
I know that, because over the decades, we never did this. So you have paper files, right? Now, it's impossible, hundreds of thousands of paper files, some will get lost. I admit that. That is something I cannot defend.
So when we digitizing these documents that are difficult to find, then what would be, how do we solve that?
They are there.
Right.
The problem is when somebody has a clinic appointment, to find it for the clinic appointment is difficult.
Right.
Right? So that is why we have started that project of digitizing those records. But it's a huge undertaking. So what we have done is start with the most recent records and go back.
Okay.
Instead of going back 20 years and doing those
come forward, because then you would continuously be coming
forward. So we're working forward and working back.
So has a separate team been hired, employed, or contract given out, a tender for somebody to be able to work on this project?
No, we are using existing RHA staff with some new hirees to do that actual digitization. But we are also moving fast. What is about 80% complete, if you have a minute, is imaging, where we can now share your MRIs, your CTs, across RHAs.
Ah, okay.
That is fantastic.
It is.
That is fantastic news.
It
So
is.
if you did an MRI in Port of Spain yesterday and happened to be in South in an accident,
They can share that
they
information
can share
quickly.
that.
Yeah.
So we don't have to expose you to radiation a second time. We don't have to waste time doing a second MRI. You get faster service. And the doctor can actually see disease progression over time.
Right.
Because he has access to your MRIs at Port of Spain for the past year.
Right. And eventually the plan is to have access to all of your medical information.
So right now, San Fernando Hospital is linked to Eric Williams.
Right.
And it's going fantastically well. Lastly, big innovation, e-prescriptions. Where the doctors can write an e-prescription, it goes to the pharmacy
And you just go and
dispense,
collect.
no paper.
Right.
That project is going on well too.
All right. So we look forward to seeing all of these upgrades, and I hope that you come back and give us some more.
Sure.
Before you leave, anything you want us to take with us, just any message you want to leave with the public as we get into this next fiscal year from the Ministry of Health.
Yeah, so the next fiscal year, we want to continue urging the public to work with us on our NCD program to be healthier. One of the things I like is the no duty and VAT on sports equipment.
Yeah.
So it means we could engage in more cricket, football, badminton, tennis, whatever your sport is. We need to get more active. We need to stop eating so much fast foods, and we need to drink more water. 3 simple things.
Simple things. Thank you so much for joining us
You're
this
welcome,
morning,
Ruckus.
Minister. Enjoy the rest of your day. Ladies and gentlemen, the Honorable Terrence Deyalsingh, Minister of Health, joining us to give us the update from the Ministry of Health as it pertains to Budget 2024-2025. We take a quick break and we come back with more on the Now Morning Show. Stick around.